Welcome back, everyone. In the next agenda item, we're going to be hearing from Dina Dobraca. Dina is a research scientist at CDPH, and today she's going to be presenting on trends of PFASs and persistent organic pollutants, or POPs, in pregnant Californians. So welcome, Dina.
Good afternoon, thank you. I will be presenting on all of the descriptive statistics from Biomonitoring California studies measuring environmental chemicals in prenatal samples. As background, the aim of our work is to have population level estimates to help assess exposures of potentially harmful chemicals throughout the state of California. And with the set of studies that I'll be presenting on today, Biomonitoring California has examined the feasibility of using prenatal samples from the Genetic Disease Screening Program. And this collaboration with the Genetic Disease Screening Program has allowed the program to obtain regional or county-wide samples without the logistics and cost of going into the field. The Genetic Disease Screening Program contains multiple programs. The one that we are collaborating with is the Prenatal Screening Program. Prenatal screening is offered to all pregnant individuals statewide to test for birth defects during the second trimester from 15 to 20 weeks gestational age. Historically, about 70% of California's pregnant population participates, and there are a number of benefits to utilizing these samples, including the standardization of their sample collection materials, in particular, the narrow sample collection timeframe. The California Biobank Program houses the Genetic Disease Screening Program's biospecimens, and prenatal samples from 7 counties total are archived, the ones shown in the map, the Central Valley counties, as well as Orange and San Diego. Prenatal samples from all other counties in the state are typically discarded after 1 month, but can be saved upon request. So MAMAs, or Measuring Analytes in Maternal Archived Samples, was a project that Biomonitoring California undertook that leveraged the Genetic Disease Screening Program to collect information on exposures throughout the state. This map is the sampling regions included in the MAMAS study. MAMAS 1, we utilized the archive samples in California Biobank, and they're from Orange and San Diego counties, and it's shown in orange on the map. For our second collaboration with MAMAS, we collected samples throughout the state, and thus we required non-biobanked counties. The regions we selected from are shown in blue: the northern counties, the Alameda, Contra Costa, LA County alone, and then San Bernardino Riverside. And then for MAMAS 3, the 3 regions are shown in green. It was the North Bay counties, San Francisco and central coastal counties, and then southern counties going down to Imperial. I want to highlight the study design differences between the 3 MAMAS studies. MAMAS 1 used archived samples. Since the sampling frame is complete at the beginning of the study, there's 2 major benefits to that. First is that you can sample across the entire year because you have all the samples accessible to you at the same time. And the second is that we were able to do a random stratified sampling design and have an equal number of participants from the selected race ethnic categories of Asian, Black, Hispanic, and white. We obtained detailed Asian ethnicity information from prenatal screening participants in the region, and the most populous Asian ethnicities were Chinese, Vietnamese, and Filipina. So we restricted our Asian sampling to those 3 Asian ethnicities. For MAMAS 2 and 3, we were using non-biobank samples, which again are typically discarded 1 month after prenatal screening. So the MAMAS 2 samples had to be collected concurrent to implementing the study. Sample collection began in September of 2015 and completed in April of 2016. Within each region, we had a region stratified sampling design. We had an equal number of samples by race ethnicity using a quota-based sampling, and with, again, the same Asian ethnicities we had selected for MAMAS 1. And then MAMAS 3 samples, same as MAMAS 2 samples, were from non-biobank counties. Sample collection collected prospectively. Sample collection began in July of 2016 and completed in January of 2017. This table summarizes the key differences between the MAMAS studies in terms of sample size, collection dates, and geography. Of note is the final column. Due to available sample volume, participants were in 2 distinct subsamples. They were PFAS only, or they were POPs only. And so you can kind of think of these as two distinct subcohorts as I present all the MAMAS data for this presentation. And then due to MAMAS 1 sampling counts, we had a limited number of Asian samples. And so all the Asian samples were put in the PFAS only cohort and none were put in the POP subsample. Okay, so next I will focus on the PFAS subsample and the findings across the MAMAS studies. As mentioned by prior presenters today, PFASs are persistent persistent environmental chemicals with known and suspected health effects, and human exposure can occur through several pathways. Our questions were, does PFAS exposure vary by demographic characteristics? And what are the trends in California residents' exposures to PFASs? So here are the demographic characteristics of the PFAS sample. By design, race ethnicity was balanced across the studies, which allowed us to calculate race ethnic specific estimates. Due to the smaller PFAS subsample for MAMAS 3, there are smaller numbers of Chinese, Filipina, and Vietnamese participants in that study. So when we present race ethnic specific estimates, we will combine MAMAS 2 and 3 numbers to have a sufficient numbers to create an estimate. When we compare our data to national data, NHANES only presents an overall Asian category and does not provide Asian subgroup information in their publicly accessible data sets. So when we compare MAMAS data to national data, within each MAMA study, we have collapsed our Asian ethnicities into an overall Asian category. So you'll see that as well in the presentation. We would have liked to have a measure of socioeconomic status from the pregnant individual, such as their income or their education. Those variables are not collected with the test request form with prenatal screening. What they do have is insurance information. So we use Medi-Cal yes, no as an approximate for that variable. Again, socioeconomic status was not part of our stratified sampling design. There is a very consistent distribution of Medi-Cal insurance across the MAMA studies. Age was not part of our stratified sampling design. There is a consistent distribution of age across the studies. As expected, nearly all pregnancies are between ages 15 and 45 years old, with most occurring in their early 30s. And next, I'll be focusing on the PFAS results from this subsample. So PFASs are ubiquitous. Of the 11 PFASs measured in MAMAS 1, 7 were detected in more than 65% of samples. And of those same 11, sometimes they're referred to as legacy PFASs, measured in MAMAS 2 and 3, 6 were detected in more than 65% of samples. And the highlighted PFASs on this slide were detected in every sample. This means that every child born to these pregnant Californians will have at least 4 measurable PFASs in their bodies. And due to the high detection frequencies of the other PFASs, most children resulting from these pregnancies will have 7 PFASs in their bodies at birth. For the next section, I'll be focusing on the PFASs listed in the middle of the slide, those 6. In that order: PFAS, PFOA, PFHSX, PFNA, PFDA, PFUNDA. Those are listed in the mean concentration measured. So across the PFAS panel, there was no consistent relationship between age and exposure, and this is likely due to our narrow age range in this study and that we have exclusively premenopausal female population. In MAMAS 1, we saw lower PFAS levels among those with Medi-Cal indicated on their prenatal screening request. And in MAMAS 2 and 3, we see that same lower level of PFASs for most of the panel, except for the PFASs that have the highest mean levels, PFAS, PFOA, PFHSX, where there was no association. A unique feature of this study design was that we had sufficient sample size to estimate PFAS levels by race ethnicity. So let me orient you to this graphic. The PFAS will be listed on the left. The race ethnic groups that we sampled will be listed across the top. The first row corresponds to the geometric means measured in MAMAS 1. The second row is MAMAS 2 and 3. A single arrow indicates a higher or a lower geometric mean, and a double arrow indicates statistical significance. So for PFAS, MAMAS 1 and MAMAS 2-3, the geometric means were the highest in Vietnamese participants and then Chinese participants. And the geometric means for both Black and Hispanic participants were lower than the other groups, with Hispanic participants having the lowest levels. So these are descriptive statistics. So these are not adjusted for other variables, but by nature of our study design, this sample is restricted on both age and sex. Next row that we have here is PFOA. In MAMAS 1, the highest geometric mean was in the white participants. For MAMAS 2-3, the geometric means among Chinese, Vietnamese, and white participants were significantly higher than other groups. And then levels among both Black and Hispanic participants were significantly lower than other groups. For PFHSX, the mean levels are highest among white participants. In MAMAS 1, levels for Chinese, Black, and Hispanic participants were lower than other groups, with Chinese participants being the lowest. In MAMAS 2-3, the levels for both Chinese and Hispanic participants were significantly lower than other groups. PFNA was the highest among Vietnamese participants. In MAMAS 2-3, Chinese participants also had levels higher than other groups. Black and Hispanic participants had levels lower than other groups, significantly so for MAMAS 2-3. For PFDA, the Asian ethnicities had higher mean levels, with Vietnamese participants being the highest. In MAMAS 1, among Hispanic participants, that were significantly lower than other groups. In MAMAS 2-3, Black and Hispanic participants were lower than other groups. PFUNDA differences by race ethnicity follow the same pattern observed for PFDA, with Asian ethnicities having high levels, Vietnamese being the highest, and lower levels among Black and Hispanic participants. From this slide that summarizes kind of the legacy PFASs, there's 3 summary findings. First, each PFAS has different relative levels by race ethnicity. Second is that our Hispanic participants had the lowest exposures, usually significantly lower across the PFAS analytes. And the third is that when we collapse our Asian subgroups into an overall Asian category, we are masking that we have a highly exposed Vietnamese population across California. So I just want to highlight, because we heard about the ACE studies earlier today. So ACE was exclusively in the San Francisco Bay Area, but these findings are consistent with what we found in ACE. With ACE2, which was the Vietnamese American study, having higher levels than ACE1, which was the Chinese American study, and significantly lower levels of PFHSX in ACE1 compared to ACE2. And so these are statewide instead of just in the Bay Area. And then this is a written summary of the 3 kind of overall takeaways of the previous graphic. So next I'm going to compare or look at PFAS trends. So nationally, PFOA, PFAS, PFHSX, PFNA have levels that are decreasing. This national data is from females 18 to 49 years old, because in the national surveys, they have not oversampled pregnant individuals during this time period, so we can't get a stable estimate as a comparison group. So this is our best, nearest comparison for MAMA's data. So MAMA's PFAS levels are consistent with the national data, both in rate of decrease and relative levels by race ethnic group. MAMA's PFOA levels again, are consistent with the national data, except for Asian participants. Nationally, Asian and white mean levels are very similar. And in MAMAS 1 and in MAMAS 3, Asian participants had lower exposures than national Asian levels. MAMAS 1 participants had higher levels compared to national data. And then either due to the fact that we are changing regions with each MAMAS study, or due to time, our rate of decrease is steeper in MAMAS 2-3 compared to what's seen nationally. And then in PFNA, while levels are decreasing across MAMA studies, the rate of decrease is not as steep as seen nationally, which again, we have a combined effect of time and geography that could be affecting the kind of trend of the MAMA studies. For PFDA and PFUNDA nationally, among Asians, levels are decreasing, while there's some evidence that levels are flat for other race ethnic groups. For MAMAs, PFDA levels are consistent with national data, both the kind of rate of change and relative levels of the groups. For PFUNDA, MAMA's participants have steady levels across all race ethnic groups, so we don't see a decreasing level among our Asian participants. Okay, so I have just focused on the PFAS as measured across all the MAMA study, the kind of legacy PFASs. Biomonitoring California's DTS laboratory measured an additional 18 PFASs in MAMAS 2 and 19 in MAMAS 3 to try to capture emerging PFASs. So to compare across studies, we've applied the same, the highest method detection limit for comparison's sake. And a lot of the data on this plot is stacked up at 0% detect. And just as a reminder, the MAMAS 2-3 sampling regions differ by region and time. So I wouldn't draw a trend line between the two, because it could be a geography difference that you're seeing in the different levels of detection frequency, or it could be a time scale. So we see a high detection frequency of PFBA. This is a shorter 4-carbon chain. It's been detected in a majority of MAMAS 2 and 3 samples, and I'll focus on this PFAS more in the next slide. I just wanted to mention that the additional PFASs that the laboratory panel that were added to the laboratory panel that were detected in low proportion in MAMAS 2 and 3 will continue to be studied by Biomonitoring California, because we're interested in emerging PFASs. So there is, NHANES has never measured PFBA in serum. So we are comparing PFBA to other studies to understand if this shorter 4-carbon PFAS is being used as a substitute for kind of longer PFAS, PFOA, 8-carbon PFASs. MAMAS had one of the higher method detection limits that we found in the literature, yet our percent detected for PFBA was among the highest that we'd seen. When we compared the geometric means and medians for studies that had a sufficient detection frequency to calculate a median or a geometric mean, MAMAS 3 had the highest mean and median values that we've found in the literature. When comparing the 95th percentile or maximum percentile reported by these other studies, there are other parts of the country and world where the range of values is higher, but population-wide, it's been most ubiquitous here. Okay, so next I'm going to be focusing on the persistent organic pollutant findings. So POPs are a class of synthetic chemicals resistant to degradation. The Environmental Chemistry Laboratory measured 3 panels in the MAMA samples. First, polychlorinated biphenyls, PCBs. These compounds were banned in the 1970s and widely used in building materials produced before then. Second, we have PBDEs, polybrominated diphenyl ethers, commonly added to foam furniture, infant products, electronics, and upholstery. A number of the people in this room contributed to the science that led to the phase out of these products in 2006 and 2013. And third, we have organochlorine pesticides, which were once widely used for agriculture and home pest control. And all of the organochlorine pesticides measured by Biomonitoring California are no longer in use in the United States. So Californians can be exposed directly to these products if they were that were manufactured before the phase out, or if they were produced elsewhere in the world. And or because these chemicals are so persistent, they have spread throughout the environment. And so human exposure can occur through soil, dust, consuming high-fat animal products, whether dairy or meat. And one of our California legislative mandates of Biomonitoring California is to assess the effectiveness of public health efforts and regulatory programs at decreasing exposures of Californians to specific environmental contaminants. So our question for the next few slides is, did California's residents to these specific POPs decrease across the MAMA studies? So first, a caveat. Again, the POP subsample can be thought of as a separate cohort of participants. Here are the demographics of that POP subsample. As a reminder, all MAMAS 1 samples from Asian pregnant individuals were in the PFAS subsample and not in the POP subsample. Within each study, the race ethnic groups that were sampled were balanced. Here, additional demographic information. Medi-Cal insurance is not balanced across the studies, and neither is age, with a higher proportion of younger pregnancies in MAMAS 1. So knowing that we have these demographic differences in the POP sample, we still ask, is the detection of these chemicals changing? So 15 PCBs were measured in MAMAS 1 through 3. And again, to compare across studies, we use a consistent method detection limit. And even though mama's samples are changing by demographics, time, and region, I have highlighted a few of the PCBs, so it's easier to sort of track the percent detect across the studies. And this is an example of a public health and regulatory success story. In 2012, 2013, most of the children born to the Mamas One San Diego Orange County residents would have had at least one PCB in their body. And in 2016, 2017, less than half the children born to these Bay Area coastal Southern County residents would have had at least one PCB in their body. And then we did the same thing for PBDEs. There were 9 PBDEs measured in Mamas 1, 2, and 3. We applied the consistent method detection limit. And I have labeled some of the PBDEs so it's easy to track them over the course of the slide. And you can see a decreasing detection frequency where 3/4 of children have at least one PBD in their body, born to the Orange San Diego Mamas One participants, and less than 1/3 of children in 2016, 2017, born to the Mamas 3 participants would have had at least one PBD in their body. So there are 7 organochlorines that were in the panel, and 2 of them were detected in nearly all samples, meaning every child born to a Mamas participant had at least one of these 2 banned pesticides in their bodies. So the continued detection of para-DDE, which is a metabolite of DDT, and HCB is of concern to California. These pesticides haven't been used for decades in the United States, though they are still used abroad. And graphed here are the geometric mean levels measured in Mamas by race ethnicity. The levels have decreased for all race ethnicities with the highest exposure among Hispanic and Asian participants. And these trends are consistent with national data. And then here are the geographic means of HCB levels measured in Mamas by race ethnicity. The levels are higher in Mamas 2 and 3 compared to Mamas 1. As a reminder, this chemical has not been in use in the United States for 40 years. And the exposure pattern appears to be fairly similar across the race ethnic groups. And these trends are inconsistent with national data. Nationally, levels are flat among females of reproductive age. So next steps. The Mamas One studies provided Biomonitoring California an excellent opportunity to confirm the feasibility of leveraging the genetic disease screening program's collaboration to help us understand environmental chemicals across the state. And as a reminder, our goal is always surveillance work to get a representative sample and to establish trends. So with the success of Mamas, we were able to launch STEPS. STEPS has a different study design and sampling frame that allows us to collect a random sampling design from the counties selected, which will give us a representative sample, and we're going back to the same counties year over year to collect trends. Additional next steps for Mamas is a few academic researchers have reached out to Biomonitoring California to collaborate with us. They want to understand sources of exposures in the Mama sample using geospatial mapping of PFAS exposure sources. A different group wants to work with us to understand additional chemicals in these samples. So potential add-on analyses include short chain PFASs or like a total PFAS, total fluorine method. And we have collaborators working with us to look at the relationship between exposures and health, a potential add-on analysis of biomarkers of immune response as like a health outcome, as well as looking at the associations between PFASs and birth outcomes, as the genetic disease screening program staff have the ability to link the sample to the birth record. So one of the limitations of Mamas is that per our approvals for the study, we don't have the identity of these participants. We can't return results to these participants. But we do look forward to working with our collaborators so that we're able to create materials and tools that would be a resource for pregnant Californians. And that is one of our next steps. So I just want to say thank you to our genetic disease screening program's colleagues for collaborating with us on this work. That was a summary of all the Mamas findings. If the panel or the public has any questions about any of the analytes, let me know and I can pull up more of the data. So thank you.
Thank you very much. That's a very interesting presentation. Do we have, we can start with clarifying questions maybe from the panel members, either online or in person. Tom?
Just a question about analytes. Was there any consideration of dioxin-like compounds? It'd be interesting to, I would expect they would have some sort of a downward trend since there's been efforts to reduce the sources of those. I know analytically they're harder to deal with, but I just wondered if they were considered.
So I'm just confirming with June Sue that some of the PCBs are dioxin-like PCBs,
Yes,
correct?
yes, that's true. Some of the PCBs would be dioxin-like.
Is there,
coplanar.
I'm not missing any other panel, correct?
Yeah. We do measure some dioxin like a PCB, also some PVD, also in terms of structure, dioxin like, but those are the very low levels. Even though we measure, our lab has a capability of measuring dioxin itself. The Jinan is the kind of expert measuring dioxin, but when we measure such a low levels, we need a lot of volumes of blood, which is we don't have. So, but always look forward to those kind of. The compound is always on our radar because they are very toxic, more toxic than other homologs, the isomers. They are isomers. So, but we do have some dioxin like PCBs or some PVDs too.
Thank you.
And just to address the sample volume, these samples have about 1 ml of serum. So that's
yeah. So just to follow up, if at that level, yeah, you probably couldn't find dioxins unless you had lipid samples. And I know you're not in the business of taking lipid samples.
Okay, Oliver?
All right, I have 2 questions, I guess. The first one is easy. I think it's easy. So you normalize the level of POPs, I think it was, on the gram per lipid. That's interesting. When people have, is this all postprandial? Is it fasted? What is the lipid here in this case? Is it total triglycerides? Is it?
Oh. It is a total lipid measure, but you would know. Yeah.
We only measured 2 major lipid, cholesterol and triglyceride. Yeah.
Total cholesterol?
Yeah, that's why we use the Phillips formula to extrapolate, calculate the total lipid. We don't measure whole panel of lipid, unfortunately. We
No, I understand that.
Yeah, yeah.
I'm just thinking about the next question. Okay, so next question is, if I look at MAMAS 2 and MAMAS 3, you said like, hey, there's some good news, and we all love good news. Okay, things the detection frequency decrease. All right. But that it decrease for things that have been banned 20 years ago, 30 years, 50, 40, 50, long time ago. But now they decrease in frequency between 2015 and 2016 by sometimes by half. I don't understand that.
So we are in different regions.
Yeah, okay.
This is
So
the limit
you
of
said that
MAMAs.
repeatedly, but
Yeah.
So I think like, do we sit here on a statistical fluke, or is it, how do we look at this data?
So this data is in line with NHANES. Let me just
Yeah. All right.
see if I have so one of the limitations of the, okay, I don't have the NHANES data as a backup slide. So I have, if you would like to see, I can pull up any of the PVDs, PCBs by race ethnicity to confirm that like within race ethnic group across these regions, levels are decreasing. One of the limitations of the study as it was designed, because I kind of think of MAMAs as an extended pilot, is we were testing, can we use archive samples? Is there sufficient volume? and that was Mama's 1. And then Mama's 2, 3 was, can we use non-biobank samples? Can we go outside of that geographic region and collect throughout the state to try to understand something about exposures throughout the state? And so that was the purpose of Mama's 2 and 3 separately. And so it makes it a little difficult because I have changing demography, changing time, and changing region when I'm looking across the studies. The benefit to STEPS, which have samples collected already, is that we're going back to the same county using a random sampling scheme. And so then we know that the only thing that's changing is time.
Yeah, I think
this one's a bit trickier. So the best I could do is I can pull up the race ethnic specified data and just say like, here.
Okay. No, I understand. So because you started with like, here's some good news, and like, yay.
I mean, it's basically the PBD levels get so low that in our data and in Haynes data, we can't even calculate medians.
Okay.
By the time we get to the more recent timeframes.
Thank you.
Right, any other questions from panel members, from the public? Okay.
Can I ask the panel a question?
Please.
So our 4-carbon PFBA, I'm very intrigued by. I tried to find a lot of comparison studies. It seems like another 4-carbon PFBS is more likely to be measured in other studies. I think I tried to look across the like ECHO cohort, and I think in 3 of their cohorts, they measured PFBS, but I couldn't find that they had measured PFBA. So if the panel has any insight, let me pull up the slide. I think it's like, no. As to if they've heard of PFBA or PFBS being used as a substitute kind of in this time frame. Here's the data compared to the other studies. What I found really interesting is that Italy's study is a comparison of contaminated drinking water and adults living outside of the contaminated drinking water zone. And they had higher detects outside the drinking water zone. That Minnesota, that's what MDH is, Minnesota East Metro study, that pilot in 2008, known contaminated drinking water site, they went back to that same population twice. And in 2014, they sent me an email with the data, so that's what's not on this slide. In 2014, they included both longtime residents and people who had moved into the neighborhood after the water system had filtration. And the detection frequency was higher among new residents versus old residents. So my working theory is it's not water. And then that last study, I was very intrigued by, they went back to the same policeman 6 months later and had very similar levels. And PFBA has a half-life in the human body of like days. And so that's 6 months later. So if anyone has on the panel has any insight as to this one or another 4-carbon PFAS, I'd be very interested to know.
Amy, I see you have your hand raised.
Yes, so I have worked on the ECHO data, the PFAS data on ECHO, and also hadn't come across that one. I just went back to look, and I can look deeper because sometimes if it's not detected at a certain level across all the studies, we would drop it, but I can go back because I have the raw data. And I'll dig deeper for you to look for that. We also did a study in Hamburg, Germany, and we also didn't find that was highly detected, even though we found 9 of the 18 PFAS that we had looked for were detected in almost everyone. So kind of a, and it's also, I think, a relatively high seafood eating population. So yeah, I'm also curious about that one that stuck out in your data because I haven't run across it so far. I had another kind of minor point. It seemed like in some cases when you were looking at the race, by race ethnicity, it was compared to kind of everyone, each race ethnic group compared to everyone else. And then sometimes it was compared to whites. I do think that it is important to do both. Because I think depending on kind of who is high and who is low, it can sometimes be somewhat misleading. So depending on what the distribution is of race ethnicity in the study population. So I think it is kind of good practice to also compare to whites as kind of the most privileged group in many cases, although even though it in this case didn't have the lowest levels, just to have or sometimes maybe to always compare to the group that has the highest numbers, just to be able to have an equal comparison as opposed to everyone else, because it can, I don't know, it sometimes can be misleading, although it seems like the findings you had were very consistent. I just wanted to make that comment.
I had a question about, the national trends that you were showing, and where it was, notable that for PFHXS, the pattern was quite different, where the white population had the higher levels. And do we have any information kind of about, uses that would explain the difference for that compared to the other ones?
So at the prior SGP meeting, Toki, my coworker, presented that PFHSX was the analyte where she found the significant relationship between water levels and serum levels. PFHSX, we assume, is exclusively from industrial sources. So whether you're living near an airport, you're living near another industrial use site. But yeah, both in national data and in our data, PFHSX highest among white individuals.
Thank you. Let's see, do we have any public comments?
Yes, we have Ken. Go ahead and unmute yourself, Ken.
Thank you. Several things. One is, for example, the comments made earlier is about like, if it's in an industrial area or close to an airport, then the impact is higher. But from the region which you are doing your experiment, can we detect on that level? That's the first question. The second one is, I know, for example, in the major agricultural area, like Central Valley and things like that, we use a lot of pesticide and things like that. So on top of like racial difference, have you looked into, for example, regional difference? Because I think some of the region which you are doing your study is very wide. So I'm thinking about more like agricultural and things like that. So these are the two questions I have. And also the third one is, sometime I notice, especially, for example, in Vallejo, we have we have like 25% Black, 25% white, 25% Asian, and 25% Hispanic. So a lot of time is the impact is a socioeconomic level. I mean, depends on who live in certain area because of the cost of living and all that, or within a region, is there a difference between ethnic background? Thank you.
So the first question was about the geospatial understanding of sources for our data. So that's one of our future next steps. We have a potential collaboration with individuals out of UC Berkeley who have been working on creating maps to understand sources of exposure. We have to independently go through human subjects approval because this is address-based data, so it's identifiable in a way, so that we are able to collaborate and so they can overlay their sources of exposure data with the addresses of the pregnant individuals. So that's a future next step. We hope to be able to do that kind of analysis. And then the second question was about regional differences in our data. So this data, the sampling frame is the prenatal screening data. It's the prenatal screening test form. And by the way that mamas 1, 2, and 3 sampled, the kind of regions as defined are not known ways to cut up the state of California. Like you typically don't sample Alameda and Contra Costa as like a region alone. You maybe sample the Bay Area as a region. So I would love to recut the data to sort of match either the region that were defined for the CARE study, for the CARE report. There's a couple limitations. One is that's a re-ask that I have put in to our collaborators with the genetic disease screening program because it's a finer geographic zone than was in the original cut of the data. The data is able to be linked to the birth record. However, not everybody who goes through prenatal screening ends up with a live birth in California. So there's a loss, and there's a loss due to pregnancy loss. There's a loss due to they left the state of California between when they were pregnant and when they gave birth. So they're on a birth record of a different state, or there's just a bad matching algorithm. And so due to poor data quality, they can't confirm that sample was matched with that birth record. And unfortunately, our match rate is 75%. And so that would be a huge loss of data if I had to go all the way to the address for these participants. I would lose 25% of my data. So I'm hoping that we are able to get a finer geography cut from our collaborators so we could get county level data on each of these participants and sort of redraw these regional lines to do the regional analysis that you speak of. And then after I have kind of the redrawn regional lines, yes, it'd be very interesting to look at it by SES. There's a couple different ways we could look at it. Again, the only variable we have from the test request form is Medi-Cal insurance, yes, no, which is a pretty imperfect variable. I would prefer not to use that one. We could use the address data to get a measure of neighborhood socioeconomic status, and maybe that will be our best approximate. If we link to the birth record to be able to get information on the education and income level of the person giving birth, then we have to lose 25% of our data, which I would prefer not to do. So those are the three ways we could look at SES within region.
Thank you very much.
Thank you. Do we have any other questions or comments from panel members or public? No, not seeing any. All right. Well, thank you very much. That was a really interesting presentation, as were all the presentations today. And so we have an open public comment period now. So do we have any requests for that?
Nothing online at the moment, but we can give it another minute.
Okay. So I could just remind everyone that webinar attendees can submit written comments and questions via the Q&A function of the Zoom webinar or by email at biomonitoring@ohha.ca.gov, and we can read them aloud here. And if you wish to speak, you can alert us using the raise hand feature on Zoom webinar, and I can call on you at the appropriate time. If you're attending in person, you can please come to the front or raise your hand, and I will call on you also. For the benefit of the transcriber, please identify yourself if you wish to make a comment. Anything coming in? No?
No.
Okay, so, we're supposed to have 15 minutes. Is that, do we have to wait 15 minutes? No? Okay. All right, then we can move on to our. Did you want to say something, Oliver?
No, there was a comment from Amy.
Oh, Amy. It just disappeared. Amy, do you want to show it again or repeat or just say what you had? in your
Oh, I
comment?
just wanted to update that I just had looked it up and only 2 out of 150 people that we had tested for PFBA had detectable levels. So not much information there. So, but keep looking.
What was the year of that? Do you know?
Actually, yes, it was a range of years. They were pregnant people between let's see, maybe 2011 through 2018.
Thanks. So any other comments, questions anyone thought of at the last minute? All right. Then I'll go ahead to our wrap up. So I just wanted to announce that there will be a transcript of this meeting posted on the Biomonitoring California website when it's available, and also announce that the next SGP meeting will take place on November 7th, 2024 from 1 p.m. to 4 p.m. and that one will be in Oakland. Information regarding options for attending the meeting will be made available closer to that November meeting date. And I wanted to thank the panel, all the presenters, the audience, and adjourn the meeting. It was a great meeting. Thank you, everyone.